Well, hi everyone, it's Pete here from the Pain Toolkit, and yes, we're back. We're back again on the 7th Pain Toolkit in conversation. We've got a really nice subject tonight. I'm really looking forward to it. I think I'm trying not to be too, I don't know, getting ahead of myself here, but maybe the best topic we've actually discussed so far.
No pressure.
Yeah, no pressure. Yeah. So, what I'll do, can we just briefly go round to introduce ourselves so that people who are watching the video or listening to the audio version, they will know who you are, where you come from, what you do. So who would like to start us off?
Happy?
Yeah, goes for it. So Bronnie's going to start us off. Off you go, Bronnie.
Kia ora tātou. Ko Bronnie Lennox Thompson aho. That is a Māori introduction. And I am a person living with fibromyalgia and teaching and researching chronic pain management. I have an occupational therapy background, and I'm in Christchurch, New Zealand, where it is 3 degrees and it is 9 o'clock in the morning.
Okay, thanks very much. Virginia.
Thanks, Pete. Hello, everyone. So this is 6 o'clock here in Canada, Nova Scotia, and I am Virginia McIntyre, and I wear many hats. I live with pain. I am also the lead of an organization, People in Pain Network, that supports people living with pain through peer support and self-management peer support. I'm an educator. I'm on many committees, and I'm just pleased to be here again. Thank you.
Thanks. Jerry?
Jerry Durham, on the East Coast in Philadelphia, aligned with Virginia. Virginia's, I'm going to say, in a more beautiful place, though. Physiotherapy background, and interested in groups of people just like this, and hearing the voices from many different places to come into healthcare, where we tend to tribe up really quick, and there's more value in hearing voices from all over. So as much as I like to talk, I'd like to say I'm here more to listen and learn.
Thanks, Jerry. Mary?
I'm Mary Wing. I'm from Australia, and along with Anita, we run the Adelaide Pain Support Network, which is an organisation that provides peer support and education for people who live with pain. I'm also on many committees like Virginia, and as a patient advocate, and I really enjoy all that work that I do. Thanks
very much. And Sue?
Hey everyone, I'm Susan Reid-Schellinck. I'm an occupational therapist. I'm on the west coast of Canada, where it's not really worried about the temperature, just excited it's not raining. That's pretty good for us.
Send it here.
Yeah, maybe. And I think I have the best, I'm 2 o'clock in the afternoon. I think I lucked out on the time clock there for sure, so thank you. And yeah, I work with people in pain, and I'm just very passionate about teaching others to help people in pain. So that's where I'm at. Thanks.
Thanks, Sue. And Seb?
Hey guys. Yeah, my name's Sebastian, or Seb. I'm a chiropractor. I think I'm the 3rd and final Canadian here. So I'm in Calgary, Alberta. So between Sue and Virginia, in my practice, I spend half my time kind of in public healthcare, half my time in private healthcare. Very passionate about the pain self-management space. So pretty young into my career, and just trying to figure out how I can kind of insert myself into that more and more. So I'm really excited for the conversation.
Thanks, Seb. And last, oh no, not last, but least, not last yet, Grainne.
Yeah, and don't forget Anita as well.
No, yeah, no, she's lost my list. Don't worry, keep calm.
So I'm Grainne. I'm in Norfolk, England, and it is pretty dismal here today, having had a lovely couple of spring days where I was able to get out in the garden. It's been tipping it down all day today. I'm physio by background, but I work primarily now as a pain coach, helping people to self-manage and supporting them and supporting healthcare professionals. And Pete and I are doing a lot of exciting work together at the minute, watching this space for 2024.
Yeah, I'm really digging it. And last but not least, Anita, who I had the privilege of meeting this week. We had a nice cappuccino and a jaw. We're chatting about self-management, etc. And over to you, Anita. Do you want to introduce yourself?
I'm Anita. I'm in Adelaide, South Australia. With Mary, I'm one of the facilitators for the Adelaide Pain Support Network. We also do some talking with patients for the pain management unit at one of the Adelaide hospitals, and give them an idea that they're seeing a multidisciplinary team now, but down the track, they're going to need to be able to self-manage. And look, this is how we've ended up. You can do this too. And we try to make this a very positive space for people when we go and we talk. So that, plus the groups that we run, keeps us fairly busy. But yes, it was great to be over in the UK over the last month and talk with people, because I've got a very different idea of what the UK is like compared with Australia when it comes to pain management.
Thanks, Anita. And thanks everybody for introducing yourself. A few apologies for tonight. Amy's not feeling that great. Keith's got to work again. Dave, who I think you met last month, who sort of does the background stuff for the toolkit, he's doesn't want to overcook himself, like, you know, he's been working quite hard this week. And who else? I don't know about Dave Flusker, absent about leave, I suppose, but perhaps I'll give him a shout, see what's going on. Anyway, on to our topic tonight. And as I said at the beginning, I think we've got a good one. And I think it sort of a bit of carries on from what I think Jerry mentioned a term last month called upstreaming, where we go upstream in how do we change things, really. And the title of tonight's one is how do we go upstream to educate pain self-management to not only patients but also healthcare workers as well. And the reason why I think this is quite an important topic, because their pain self-management, as what I've learned over the years anyway, especially healthcare professionals, that is that while they're in medical school, their respective medical school, supported self-management, pain self-management really is on the curriculum. And I always remember a Canadian doctor tell me many years ago that it was self-management is something expected that they had to learn while on the job. And it's like the equivalent of you know, someone teaching someone to drive like that. Well, you know, you've gone backwards, you know, you've gone forward a few times, but now you've got to work out how to turn left and right, you know. So in a way, and so what this is why we've got so many people, not just here in the UK, but also around the world, that are the numbers of people going up who are living with persistent pain isn't going down, it just keeps going up. And I can only speak for the UK. When I first started doing this, there was only 7.9 million people. When I say only, that's a lot. Only 7.9 million people living with pain. And then in 2000, it jumped up to 14. And then about 4 or 5 years after that, it jumped up to 28 million. So, and I think the International Association for the Study of Pain, they're quoting 1 in 5 people now around the world living with pain. So what's going on, you know, because it just can't, it's unsustainable, you know, with the amount of people, and there's so few people that do work in the pain self-management. And so if I sort of just give a bit of what I've tried to do over the years now is when I'm always looking, how do we, I think one of the phrases that I learned when I worked in the NHS was part of our job when we was on the NX expert patients program was about building capacity. You know, how do we pass on the message to other people who then go on and support other people, you know, other people living with long-term conditions, etc. So in a way, I suppose that rubbed off onto me, and since I've been doing the pain toolkit, I've always looked at that. How do we build capacity? Like, how do we get to other Pete Moores, other Virginias, Jerry's, and, you know, all like Seb's and Mary's and whatnot? How do we get out there and just go upstream try and fix this problem, because and it's a problem. It's got to be fixed. It's where med schools have got to start. It's not a choice anymore. It's really becoming a must, where they include self-management within their modules. How do we get them to change their mind? Do we need to train those guys and up to teach it? But also, and I think that's if anything, it's educating the healthcare workers first, because and then come back, and it still sounds a little bit back to front, because it's no good, as we found out when it was in the expert patients program. I think one of the modules on it was that one of the participants had to write a letter or go and see their GP and tell them what's going on. But the GP would sit down, because I think that was a week 5. They'd come back a week 6 and tell us the GP was going, well, what the hell's that? And so it's a little bit back to front thinking. So this is why the importance of getting healthcare workers on board probably first. And when we start, we'll be launching the new Pain Toolkit Academy later this month. So really, it's when as I say, over the years, I'm going on about. I know I was just saying that, Bronnie, is that over the years I've tried to think, how do we to keep it low cost? How do we build capacity? And that's why I've got involved with probably technology. Well, I started doing workshops on Zoom. I can't remember now. It must be 6, 7. I can't. It might be a little bit longer, 8 years ago or whatever. Because what about the people that live in the rural parts of the community that will never ever get a chance of? They're living too far away from a pain management program, etc. And then in recent years, I've after working with Teesside Uni, looking at technology, so I bumped into a Japanese doctor who was using this VR virtual reality platform where you didn't need a headset. You could go and see VR with your phone or your computer or your tablet or whatever. And then then to work with Teesside University, where there's an AI Pete where people can dial in. You can go into it now 24 hours a day, 365 days of the year, and have a conversation with me, ask the questions, and I can verbally, or we can type it in, etc. So to me, it's all. Do we need to use more technology in how we communicate or educate, etc.? So really, in a nutshell, now I've probably gone a little bit too long here, but I want to hear from everybody really. What's your battle plan? Is there a battle plan? How do we go upstream? Do we need a little canoe, or do we need a ship? A barge or something? How do we get upstream? How do we start? Because we've got to start changing stuff. There's no doubt about it. We can't keep talking about it. We've got to start doing it. So anyway, over to you, Bronnie. You had your hands up, so over to you.
Yeah. So I teach 5th year medical students and postgrads. That's a big part of my job. What we've found with some work that Dr. Elspeth Shipton has done, looking at the pain curriculum in undergraduate medical school training and undergraduate other health professionals training, and finding there is very limited information on pain anyway. And that's one of our huge problems when we come to pain self-management. Because if your only understanding of pain is that it's activity in nociceptors, and as a doctor you're meant to fix that, you are going to come about this lived experience and the self-management thing with a really, really weird hat and in a place of naivety. So to that effect, University of Otago has implemented a complete review of our pain curriculum for all of our undergrad medical practitioners, medical students, and we have instituted a new curriculum for every student that goes through, and that's consistent across the 3 different medical schools that we run at University of Otago. Inside that, we are making sure that it's not just here are your nociceptors and here's the biology, but here is a person who lives with pain, and what does that mean and feel like? So what I've done is I've tormented my fifth years. So I make them put their hands in 4-degree water for up to 2 minutes, and I get them to rate their pain. I actually start by saying, how much pain do you think, what pain intensity would you get from putting your hand in this water? So the expected pain intensity. And then some of them will volunteer to actually do it. I'll never get the whole group. And then I get them to rate their pain as well. And then we talk about why, even though it's the same stimulus, the water is all 4 degrees, why it is that in a group of 30, there are ranges of pain intensity that people report. And why is it that what they actually experience and what they expected to experience, how are they so different? Why is there such variability? So we can start talking about the fact that pain is not just activity in the nociceptors, that it's a human experience. In terms of the pain self-management, I don't think within a biomedical model and that's what our doctors are, that's their emphasis. Even though they're bringing in the psychosocial, they find it hard to integrate, and they're still really looking at how can I fix it? Until we give them a better understanding of that, it's going to be really hard for them to see the value in helping people who live with pain live well, because there's still an assumption that they can fix it. Damn it. And it's been a very long time that I've lived with my fibromyalgia, and I know a bit about pain now, and I haven't been able to fix it. So I want to try and convey that. So from a health professional perspective, the sooner we can help health professionals recognize that we simply don't have ways that get rid of the most complicated pains, we're never going to get them to acknowledge that some people like me and you guys will need to learn to live alongside their pain, because there's still this belief that if we find the cause, we can fix it. Pain's just a symptom. So that's my sort of tuppence worth on what we're trying to do, and the challenges there are, and the fact that I know, seeing in the chat, that the limited attention to pain inside curriculum across all clinicians right around the world is actually, it's everybody. We just don't make pain important. It's weird, right?
Thanks, Bronnie.
So that's where we start.
Thanks, Bronnie. Susan, did you have your hand up? Sue, did I see your hand up?
You know what? I was clapping for Bronnie, but for what you were saying at that moment. But yeah, I can add something. It's kind of a question, and sorry, Virginia, I'm kind of going to call you out a little bit. Just ask, yeah, it's a yes or no if you want it to be. So I was at a program and I got the team going on education first, primarily because it was a 3-year wait to see the physicians. So management bought into that, and what we found is that 10% of the people that went through, and I think I've mentioned this before here, this were people who failed, I hate that term, failed everything else. I think we failed them, but anyway, after self-management and pain education, they felt they didn't need to see the doctor. So, we've seen the good results, we know it's there. Anyway, my question or my thought is to Virginia and to anyone else, because I know, Virginia, you were at the CPS and were you not? Yes, and the National Forum on Pain as well, which I was invited to, but sadly couldn't make it. So we talked at an event last month, Pacific Pain Forum, about inverting the triangle. So the idea that, and this was the head of the Canadian Pain Society talking about inverting the triangle. And so that's what essentially we did in our little clinic, and it worked brilliantly. And so I love that I heard that. And it was quite a topic for that Pacific Pain Forum, which is in Vancouver, BC. It's a day-long event, and it kind of got repeated multiple times. And I was pretty excited about that. Yeah. So Virginia, I'm wondering, at the Canadian Pain Society, was that a topic that came up, or in the National Forum for Pain, did that inverting the triangle, did that theme continue on?
So what do you mean by inverting the triangle? Being
Sorry,
self-management your first?
Thank you. Yes, sorry about that. So the idea is that there, of course, you have a triangle, and at the top of the triangle is the physicians, right? So they're there, so they get the needles, and that's where people enter, is there, and then the very, very bottom is sort of the self-management stuff. And the idea is inverting it, meaning that the first thing they do is self-management, then they look at lifestyle stuff, then they look at, you know, all the while with medications and stuff like that. But at the very last would sort of be interventions by pain fellows. So that's what they mean. So the idea is that we're putting self-management first and pain education first. Yeah. Yeah.
I love that. I love that. And I know I've heard that. I haven't heard those words inverting. Now, there wasn't conversations there about that at CBS and the National Congress, but I think that's the thing we need to bring to the table is the self-management. And I think with us who are in groups and that, how do we get the clinicians to buy in? And this was one of the topics was discussion is brought up as a fee structure. You know, and I brought that up with the Congress, when my armchair discussion with the National Congress. If we're going to invert the triangle, our clinicians need to have more time with patients to have these conversations. And about that, they need to be able to bring in our community organizations in order to support it. We need to break down the silos. And this is a whole, so I do love it. And there was a lot of that going on about priorities and setting priorities. And we had the opportunity to discuss these things with the Minister of Mental Health and Addictions. But I don't know. To me, I'm always feeling, are we speaking to the choir? So, and how do we get, and well, like what Mary does and what we do is about self-management, and Pete does, we're all about self-management. So I think a lot of it, and we've talked about, is providing outcomes, measurable outcomes, so our clinicians see the results. Just telling it to them is not going to do it, but providing outcomes for them and the financial benefit to them, and or economical benefit to them. And, you know, because really in the long run, if you're seeing your clinician less, it's going to be an economic benefit that we may get a little more uptake.
Okay, thank you. Mary, you got your hand up?
Yeah, I was just going to say that I think that allied health is getting this message across much better than medical people. I help run workshops with a lecturer at Adelaide University for second-year physio students, and have done for a couple of years now, and they really appreciate that sort of input coming from a real-life patient, because they probably haven't seen many up until then, and that conundrum that they get given as to, well, this is not a person with a sprained ankle, this is not a person with something you can fix, this is a person with a very complex condition. What would you do? And I managed along the way to get some words in about language and all those other things that go along with it. And I think that helps. But how you break down that barrier and get into medical schools and do exactly the same thing, I'm not sure. Because you're right, their training is purely biomedical. But there's another issue too, at least in this country, and I would say there is all over the world. If just imagine that we did have doctors that were able to teach and fully understood self-management, where would they get the time? So therefore, they need to be in partnership with people like us, people like me, people like Anita and Virginia, and people who run peer support networks, so that they can then gently sort of be in total support with the patient, but also in sort of some sort of partner, not partnership, not a formal partnership, but something with us, and we need more groups too, but you're always battling uphill. So, you know, that is my solution anyway. It might seem a bit simplistic, but I think that would work if it could ever be done.
Thanks, Mary. And Grainne?
Yeah, all good conversation topics, aren't they? My brain's going on a bigger, more global level. I've been typing away in the chat, and I kind of think you know, I think everybody makes a good point. I would agree in general, probably allied healthcare professionals, physios and OTs certainly are, you know, more than comfortable, a bit more talking about, you know, self-management earlier doors. And certainly there is absolutely this problem with medical schools and medical training and the way that model is taught. But there's also that thing of actually, I wonder now, does self-management, supported self-management from a pain perspective, but maybe even from just a general life perspective of any chronic health conditions, does it need to be a bit more of almost like a public health thing that everybody needs to be learning from an earlier age how to be more, I don't like using the word resilient because I think that's used a lot of the time in not the best context. So, but just take more ownership of their own health from an early age. I see almost one of the challenges, and this is obviously coming from a system where we have this full national healthcare service, which is free from the point of birth to death, and so on and so forth. But that's almost taken away people's belief that, you know, to a degree that they need to do anything with their own health, you know, and that therefore there is an expectation of people to be fixed. And then that creates the expectation of healthcare professionals to fix them. Do medics and physios and other people need to be actually looking at sort of more public health generally in their training as well, you know, in terms of what can we help and support the general public to do to look after themselves, to understand how to manage things and to understand how to take care of themselves and to take ownership. So that's obviously a massive thing, but, you know, is that somewhere where we need to be starting? Do we need to be, because we can't, this model has been going on in this circuit for a very long time now of what we learn in physio school or medical school, everything getting more and more biomedical on one side, and then on the other side, everybody's shouting about how it's got to be anything but biomedical and it's got to be all about the person. And clinicians, I think, are struggling to reconcile the two. And how do we get that? How do we get that changed? I don't know.
Thanks, Bronnie. And Susan?
Yeah, thanks for that, Grainne. I was actually, I liked all your questions, and I hopefully someone will respond. I was kind of responding to the chat before. So what's worked here is in BC is that we, the healthcare professionals, have gone to universities. So I was teaching and I have for almost 10 years now, I taught a 2-day course for OTs. It was sponsored by our national OT and from Pain BC. And we went to UBC and said, please come for free to this course. We think your students need it. And when I started, there was about 55 students. So I've been going yearly since then to teach at UBC. It was a 5-hour course. But this year they said we need more hours because our students want this. So I think it was from the health professionals coming in, and I know the same for the physios has happened and the doctors at UBC. I don't think it's perfect. I think we're still far below what we need, but it's come from the professionals, and now it's coming from the students saying they want more. So that's really great. And we hear it in the people as well. And I think so that's great that we can do that. But I think the stumbling block is going to be what we've mentioned earlier, which is where does the funding come in for? I have trained so many OTs, but there's really no funding for OTs to do this work unless they have, automobile insurance or WorkSafe or something like that. So I think we've got, it's not just where, how do we get there, but how do we keep going?
Thanks, Susan. Virginia?
One good thing was that the Canadian Pain Society, Alberta, had talked about their new pain strategy. And, is this something if every province worked together and did a pain strategy? It's not like you have to set up your own, you don't have to reinvent the wheel. There's some really good work out there, and you just have to copy them and put some money into it. But what Alberta also did is they had the lived experience, people supporting them right at the beginning, hearing their views, hearing ideas, bringing in peer support, and not peer support groups right now, but in part of their self-management. So, and then the support groups, but it's evolving. And if we could, every province do that, or in Canada, could we just have a federal thing and say, let's do it, because the evidence is there and the work is there how to do it. I mean, pediatric pains actually have a pain management standards. I mean, we have action plan for health, you know, and I don't get it when we have this amount, a huge population who are living with pain, and also globally being the largest reason people are on disability. So sometimes I'm just missing something.
Mm. Yeah. Sorry, Bronnie, I just see a hand up.
Thanks. I was thinking about the public health problem, that this is a public health problem. And I guess part of the issue that I've discovered here, so I was just pointing out that our population health departments they've not got engaged with our pain strategy because they're busy dealing with diabetes and whatever. But I remember when I presented to our Ministry of Health Women's Health Policy Strategy group, and I pointed out the numbers. 22% of New Zealanders live with chronic pain 3 months and longer. That's higher than asthma, diabetes, hypertension. You know, that is the reality. So part of this is about how we ensure that those numbers get elevated. We let people know. And I don't want to see the oh, it's a terrible thing, woe is me, I have chronic pain. I think pain heroes actually present media in particular and government departments for you know, where again, unlike the US, we've got a publicly funded health system generally. If we start to elevate the voices of people who live well and the way that they do that, we do that, then we start to raise the profile. First of all, there's a lot of us out there, lots of us. We elevate the fact that there are ways through this, that it's not terrible. I mean, it's hard, but it's not terrible. And I think getting that the attention, comparing the chronic pain prevalence to the prevalence of these other chronic disorders that have already got the limelight. You know, diabetes in New Zealand is a really big problem, but it is not nearly as big as chronic pain is, and we do not have yet a proper implemented chronic pain strategy. So that's helpful. In the chat, just very quick one, the thought that why do we need to wait for people to go to a health professional, that Jerry raised that, and I agree. And I think the fact that we can put these messages out on social media, where they can be picked up, where they can be viewed, the work that we do is probably more effective in some ways than other, you know, waiting for a clinician to do it. The challenge is that people are afraid because the pain feels like acute pain. And what if I've done something scary? And what if I do myself harm? That's probably the bit that's the challenge. And I'm not quite sure how we help people feel confident to start doing stuff even early in the stages of having a pain problem. So I don't have answers for that part.
Thanks, Bronnie. Jerry?
Yeah, Grainne finally typed something in that poked to me, nudged me. And by the way, wait till you see, Grainne, you know, what I pulled up when we first started this conversation. I wanted to make sure I got the quote right. I want to read a quote I pulled up. It's by Upton Sinclair. It is difficult to get a man to understand something when his salary depends on his not understanding it.
Yeah.
I go to that quote frequently for myself. If I have a reaction to something, right, I will go back to that and say, what are my, right? What skin do I have in the game? What are my biases? You know, and when we go, I love this conversation because I said this at the beginning, we got to have all these different angles coming in, right? And we have to, because it's too complex, right? We love to oversimplify, but then we like to overcomplicate. So I like to call this the middle, where right? We bring in these different things and we talk about it, but the finance side of it, right? And by the way, in America, so I'm going to speak for America, even though I hear most of the similar things, I'm just going to sit here and say, regardless of payer source, by the way, whoever brought that up first, I'm sorry, that might have been you, Grainne, saying, well, in your system, but Virginia. Yeah, Virginia. I heard you saying something and I was like, oh, okay. And then, but everything you said after that was completely the same as here, right? Whether it's tax funded, whether it's like private insurance in the US, I got to tell you, it's the same. And the research in the United States, I want to use two examples here. Low back pain, right? Huge pain. Low back pain, 81% of the population in America has low back pain. The research, and there's been recent research conducted by the people that matter, the payers. So we know it's legit research. That's what's kind of sad, that they have the most legit research. But showing that the further a person, and this is why I posted that question, Bronnie, why through, and that's why when I heard the inverted triangle, I was like, yes. And that's the first time I've ever heard that. The further someone gets into the system in the United States of America, the worse everything gets. Financially, outcome-wise, physically, emotionally, psychologically, it gets worse. It gets worse. So we then, me of 32 years with my physio degree and all this money and energy invested and all the skills and everything, I have to stand up and own the fact that my job now is to keep people out of the current system that I've been in. And so what I would challenge the healthcare providers who are thinking, right, I can't help, or this isn't for me, or I won't make money. And where I would like to say I'm helping to do what Pete is setting an example for, and Pete has been a huge influence on me, is showing and talk, well, not showing, I'm getting the information from you guys from other places, and then making sure people are aware that how we can take these skills further upstream. And so how do we, back to Bronnie, what you said, and you were piggybacking on a lot of other things, how do we get the word out that, hey, Jerry, when you have some pain, you have more than one choice. Let's just leave it at that. You have more than one choice. We know traditionally this has been your choice. We want you to know other choices, because what the research has also shown, and this is where I think our expertise, the providers, really come in, is the triaging of people further upstream is actually the key. It isn't just get to them further upstream. Obviously, what do we do with them upstream? So having a triage system in place. But as you all were talking, I'm thinking about Pete, I'm like, there might be some value on having some lived experience people involved in the triaging too, right? That's, I'm going to have to, again, that resources thing, maybe the triage team is 3 or 4 people sitting together who are all on the same call and come up with some way to, I'm making stuff up now, score the call, but everybody's input is equal, right? And to get this person, because God, the research, it's so, I just did an interview with someone for my podcast. It's just so blatant and it's so obvious, and everything is, if we keep people out of this, our $4 trillion US, I'll let you all convert it to your dollars. By the way, it's trillion. It's not million. It's not billion. It's $4 trillion spent in America, and our life expectancy has decreased, right? So we have this keeping people out of the system. That this has been my mantra as a provider and the businesses I'm working with. How are we going to get your providers further upstream to serve greater value? And by the way, the payments there, that's the other thing. And that's not for today, but I'm just going to say it out loud. So I'm going to stop there, and I appreciate everybody. And I will chime in later because I have a great example of this being done. So when people want to see an example that are hearing this, I've got somewhere for them to go. So I'll stop there.
Thanks, Jerry.
You knew I had an opinion on this beat, so.
That's like, no, fine, Jerry. Anita, I know I've got to tell you that if you want to say something, there's like the feature there called reaction. I put like a little yellow hand comes up on your screen, but I see you put your hand up earlier on. But Anita, do you want to say something or?
The reason I put my hand up was just to work out that inverted triangle. But I think one of the important things that we need to somehow get across to the entire community. Having talked with a lot of people around the UK, a lot of people, including in Australia, seem to think if the doctor says to do it, then that's what I need to do. And I think we need to educate people that it's their body, their mind, they are in charge, and they can challenge what the doctor says if they do it nicely, so that they are in the driving seat. And that would then stop people. For example, I hear people at barbecues saying, why do I need to worry about my diet? I pay a lot of money on my cholesterol lowering tablets so that I don't have to worry about my diet. And they've got it all back to front. So maybe putting the patient back in the driving seat.
I'll ditto that. Susan, did you have your hand up a minute ago, or I don't know if I'm getting hand flashing. I see,
I was slowly clapping.
I see. I don't know if I'm seeing things now, but I see. Bronnie, you got your hand up.
I think that putting the person in the driver's seat is a really important thing. The challenge is how to help people feel confident to have those difficult conversations with people that you go to thinking they have this incredible knowledge. Because, you know, we expect that our medical or health professionals have more knowledge than we do about what goes on. What we forget as people living with pain sometimes is that they don't know our lives and they don't know everything about everything. And that's the part that I want to try and say, let's democratize this and say, hey, we as people living with pain, yeah, and I've got other roles as well, we can share what we do. Our voices are really powerful, persuasive, authentic. And, you know, I'm not going to be a social media influencer, but there are people out there who live with pain, like the people in the ADHD community, who are out there, like Pete, putting it out there. And that's not the only thread, but one of those skills we need to impart in our online presence is how to have those difficult conversations, that it is actually okay to ask your provider, what are you thinking? What are you saying? Why do you think this is a good idea? There are tools out there for this, like the Ask Me 3, which is, you know, tell me why I need to do, why is this important? Tell me what I need to do. Tell me why I need to do it. That's a really good strategy. But we probably need to help people feel okay to do that, because this fear is, if I do it wrong, then it's my fault. I've failed. That's what I hear from people with pain. You know, the reason I've had a flare up is because I did it wrong. That's not quite the case, really.
Thanks, Bronnie. Grainne?
Yeah, I mean, great. All great points. What I wondered was, though, what I'm curious about now is kind of what are some of our ideas for going forward of what we're going to do. I will just say one thing in response to Jerry. I used to always joke, Jerry, whenever I was, and I still do see my private patients, I had the world's worst business model for a private practice, because my business model was, I want to see you as few times as possible, ideally once, and then you're going to feel reassured, know that you're okay, and you're going to go off and manage. So, but I was okay with that. But I do think part of the problem is this vested interest in, actually, if it's your livelihood, it's hard to kind of, you know, be that altruistic sometimes for people. But one of the things that that Peter and I are doing, so I'm just going to sort of start to talk about little changes that we might start to make with that kind of upstreaming, is this idea of prehab that we've been, when Pete and Keith had done a prehab pain toolkit, and I've been talking with other clinicians in the country with the very long waiting lists that we have for people in this country, at the very least. So we have very almost very long waiting lists for people to get in to see any sort of healthcare professional, and then very, very long waiting lists once you've seen that first healthcare professional to then get anything else done if you need something done. And so we're looking at, and I'm certainly looking in my own practice at offering sort of it as prehab is a thing. You know, if you've had a diagnosis of a rheumatoid condition from a rheumatology consultant, or and you're not sure what to do and you don't know who to turn to, you don't know what the best advice is, come and have a couple of sessions to understand what you can do and feel empowered and send people off in the right direction, and get more and more clinicians involved in seeing themselves as that kind of resource to just help people feel safe and empowered. If they're waiting for hip replacement, for knee replacement, for surgery, for endometriosis, for anything else, you know, come and talk to somebody for some prehab, get some good advice, and get signposted to all of the stuff that you can do yourselves. Because as Bronnie said, there's so much good stuff out there, but it's getting that out there to people. So that's one of the ways that Pete and I are doing it. And I'm really curious to know what other things anybody knows about locally to you that we could maybe add to that.
Thanks, Grainne. Just before I go on to Mary, what I like about this prehab concept, and I know it's not new, it's other people have been doing, etc. But it just seems that what we do in pain self-management or pain management is we're fighting fires. You know, we're constantly firefighting all the time. You know, we wait until someone's in big problems, and then we, you know, like we put the capes on and we come to the rescue, etc. Like, you know, but it's the idea of prehab, not just for pain, but long-term conditions. I mean, why do we wait? Why do we wait for some, you know, having a some sort of treatment, or an operation, or some sort of you know, knee, hip, or whatever. I'm just thinking of other stuff. I mean, is that stuff in healthcare? Well, what, you know, as I was telling someone down the gym the other day, like what we're doing, and they said, "Oh, it sounds like rehab, but in reverse." You know, in other words, so instead of, you know, someone's struggling, you know, they've had the operation and now they've got to try and get moving. Why don't they start learning how to move before, you know? And I remember up at Input, when I was doing these implant spinal cord stimulators, is it? But there was a priority before you actually went on the operation to have it implant. You had to go on a 2-week pain management program so that you learned how to manage after you had the implant. But people were then finding that that 2-week program had such a fast effect on them. They said, "I don't want the implant. I don't need it." You know, so it's, you know, I think we've got to get in faster. But I think today, you know, it's about how do we get in there. I mean, it comes back to that question, as Grainne said, is how are we gonna, you know, tonight it's about in this thing is how do we get in there? How do we start hitting the brakes on what we're doing, where we're fighting fires, but how do we get in there, get in there earlier, as Jerry said, you know, be part of a triage team or something like that. Who are we missing out? Who have we got to meet to get things done, to take, you know, so that the decision makers start making better decisions? Sorry, I went on too long. Mary.
Oh, no, look, that's okay. I was just going to say, we have a different system here in Australia. We've got a private system and a public system. And I guess our public system is, correct me if I'm wrong. It's all right. It's a thing telling me to lie my hand. The public system, they teach pain management pretty well, I think. I can speak especially for our state, and I know in other states there's some pretty big programs that ours have even been based on, and that does very well. But if you go to a private pain specialist, you will have, they're very interventional. You will have injections. You may even have a spinal cord implant for which there is very little evidence of success. There is a lot of other things they do that I don't even know about that have got very complex names, but I don't know how you would ever get that because it's their livelihood, I'm not quite sure how you would get that sector of the community to come across. But the others are already there. They're already teaching self-management. And, you know, the pain clinic, one of them, or a couple of them in particular, will refer people to us for when they're finished for ongoing support, particularly people who are isolated, because it's really hard if you're isolated and you can go right back downhill again. There's nothing worse than being alone and being in pain. So I'm not sure what the answer is here. It's a little bit different to other places, but if we could sort of convert that other half to at least think about self-management strategies, we might sort of, well, some of them may do that. I don't want to sort of bag the whole lot of them, but some of them may already do that. But that is another issue that I can see. I can see all these issues, but I haven't got the solutions, which is what we're here to try and do. I know.
Okay. Thanks, Mary. Anita, what solutions have you got?
One of the things that I have with my physio practice, because I wasn't involved with insurance or anything when I hurt my back, I've chosen my own healthcare team. Now, my physio practice, they've got something that I can't remember, I'm still too jet lagged to work it out, but they've got a thing like prehab for hip and knee replacement patients. And they've taken it from somewhere in Scandinavia, I think. And people go along once or twice weekly for about 12 weeks, and then they decide whether they want to continue or not. And it's specific exercises so that they can build up what they need to do after they've had their replacement. And with a lot of it, about 90% of the people then don't need to go ahead with that replacement. So maybe along with the private pain specialists, maybe they need to link them in with good physio practices who have got these programs in place who understand pain. And I don't know how to, like, we're very careful with our pain support network not to recommend specific physios because we do, or doctors, because we don't want to be seen to be unethical with anything, or to say you must go to this place or you must not go to that place. And that opens up a whole can of worms if we do. But I do think that it is vital to have a physio practice or something similar in conjunction with these independent pain specialists where people are seeing them privately.
Thanks, Anita. Jerry?
Yeah, so, so talking solutions. So here in the States, right, one of the big forces going forward there's actually traction and it's happening, like some examples others have used in other places, is the way to go around. Unfortunately, the insurance industry, the private insurance, well, it's mostly all private, because actually Medicare is not the largest insurer in America, which is government funded. It's the private insurance by far. There are ways, without getting too in depth, to go around that, so private insurance is provided by employers in America, and it's law, it's federal law. You have to as an employer. So the very large employers have a very large incentive to keep their healthcare costs down because they're paying parts of the premium for their employees. So there's huge potential, huge opportunity. And I'm going to speak to physios currently are making inroads in going around the payer and going direct, what we call direct to employer, to then get access to very large groups of people and diverse groups of people, right? In different types of settings. I mean, thousands, if not tens of thousands, if not hundreds of thousands of people, and get to practice in the manner that we're talking about, where they get to be, for the MSK side, they get to sit with the employer and draw out a program, Anita, like you're probably speaking to. They get to draw out a program that when someone has low back pain, they have to go through this process. And the process starts with that physio. And again, everybody knows the goal. The goal is happy employee. If you think about it, ultimately, the employer's contracting with you to keep happy working people. Let's face it. Let's not sugarcoat it. Now, we all know good things are going to happen, right? We keep them out of the system, cost goes down, pain goes down, all these, and yes, there has to be a correlation with outcomes, because if people aren't getting better, then the sick days won't reflect it. But this is a great example in the States. And I just posted a 3-part podcast. You know me, I love to talk. I just did a 3-part podcast on this with a group that are doing it, talking with their executive team, with the physio team, and trying to give people inroads. This is one huge solution, I believe, in the States that is going to be big to get upstream, to not only help people, I'm going to say people with pain, but to keep people out of pain, right? So kind of some of these starts. Now, again, back to Anita, right? Who are these groups that are running this? I think what's going to happen is they're going to be accountabilities that physios have never been challenged with here in the States, that are going to force them to deliver a better product. And that is better outcomes, because there is a potential to be paid a lot of money, a lot more than we would going directly to the insurance side. So I do want to share one other example. So that's a big example that's really, it's been going on in America, but it's finally getting some traction. And that to me is almost this quintessential going upstream and getting people early. And the key to this, again, is the triage that we talked about. So these groups are having to work with the employers, with other people, right? And it's a team approach here. This is the beauty of it. It's not the physio walking in saying, I'm in control. It's like, no, it's very transparent. So it's a kind of a careful what you wish for thing in America these days and I know practices who won't do this because they don't want the transparency. So I think it's a good thing. I'm going to give one other example I think that fits well. Women's health. I just did and met with a provider here in the States running something called Operation Mist. And she is doing, I say it and I'll say it out loud, she's doing the Lord's work. And right, instead of waiting, so America, the number one elective performed surgery in America is C-sections. Number one surgery in all of America. And so what do, right? We sit and we wait for someone to have a C-section. Sorry, physios. And then we say, come to us, we'll help you. And there are many, many people out there, and I'm going to say it out loud, mostly women, making inroads into this side too. And Dr. Catherine Sylvester, who is a physiotherapist, and I would love you all and anybody listening to this to go to her website, because I think her website shows exactly what this needs to look at. And it's Operation Mist. Her resources page is not her frickin' staff, is not all the other providers. Her resources page is links to chefs, right? What do moms need? Chefs, transportation, I mean, all kinds of stuff. When you start clicking through here, so that team approach and that research, that resources page, right? You think the resource is going to be the products they're selling and everything. Nope. It's to all these other experts that she's brought in. And I'm just going to go one step further with this. So she's not sitting around and waiting for postpartum mom. She is making the connection further and further and further upstream. And she now has clients. She has now started premenstrual parties, she calls them. And she is starting to gather up women. And her youngest client is 7 years old through the premenstrual program, all the way through 78. So if we want to talk about taking control and educating and building up resources, I think Operation Mist in the US is a fantastic example. And by the way, she's got funding, she's got people paying out of pocket. It's, it's rarely an insurance type coverage. And because of all these, and all, by the way, the resources themselves can help to fund some of these programs too, right? So I just wanted to share those two examples with everybody of what I see as solutions here. And by the way, that's a very, very small percentage, but solutions of people going as far upstream. I can't imagine going any further upstream for for helping pregnant women than premenstrual. So these are great examples. So thank you.
Thanks, Jerry. Virginia?
All right, thanks. Wow, Jerry, I thought that was really cool about this Operation Mist. I mean, you talk about resources, and I like how she's bringing in community. And if you're not engaged in what's happening in your community, it is a miss. It is. It really
You're
is a miss.
exactly right. And I do want to say the community and the community of people bringing, so, right, she brings them together, and then what do? They help each other find resources, right? It's beautiful. And it really is. I should have said that first. It is built around the community. Thank you.
Right. The peers, and that's where this peer support comes in. So it doesn't mean it's a whole group or it's one-on-one. It's whatever. It's a community knows, and they know what's out there. I think a huge thing we need to really look at is one is accountability. And I like how you talk about that with the physiotherapist, because if you're not making an improvement, then you're doing something wrong. So, and I think that all comes back to the education piece, and we've talked about it. Our healthcare providers have to be educated, but so does our public. Our public has to be educated for chronic pain. My background is in healthcare, and when I got this post-surgery pain, and I had no idea what was going on. For years, I was out of work, and we know we're on the table here. What comes with that? Being out of work, being with insurance company, being with people who don't believe you, the suffering. It's So if I knew what chronic pain was, maybe then I would say to the physiotherapist, do you know what chronic pain is? Because it took 5 physiotherapists and 2.5 years later to find someone who knew what chronic pain was. They do the same rotator cuff surgeries or exercises over and over and over. I'm like, it didn't work the first time. What makes you think it's going to work the next time and the next time and the next time? So I think if our public knows what chronic pain really is, and we start in the school system, maybe we'll know what to ask for and what to look for and how to question our healthcare providers, because a lot of them don't, and then get to the right person sooner.
I like that. Thanks, Virginia. Bronnie? Yeah, I think you may need to unmute yourself, Bronnie.
There we go. I think we can learn a lot from the sort of upswell in awareness of neurodivergence, because now you can jump on and look up adult ADHD or adult autistic or women with ADHD, and there is just a wealth of information from clinicians, from people living with ADHD, and that is kind of, you can almost be, it's hard to miss it. And I think that is part of what we need to do. I also think that we as a group, our group, and I know that we've started this, need to leverage off the diversity and the experience and the skills and the knowledge that we have, to keep banging on the door of IASP, of WHO, of our international occupational therapy, World Federation of Occupational Therapy, International Physio. We need to do that too, because we know we have the education, we have the skills to start saying, you guys, listen to what we have to offer you. We can shape what self-management looks like without having to think that we need some kind of stamp of approval. We are the stamp of approval. Just a thought.
So what this comes back to the levers. It's the here in the UK we've got general election coming up, whenever that will be. Hopefully we'd like it tomorrow, because we're struggling at the moment, but mate, it looks like it's going to be later in the year. And I know I'll come up with some like a pain toolkit agenda, really, like what we really need to see, But I mean, I know it's how do we it comes back down to money, and I think with the politicians, I always remember when I lived down Romford Way, I contacted a local MP. She was a fairly new MP, and I think they need something to hang on to, And she ran with me on with the back pain thing, and she started asking questions in Parliament about back pain and stuff like that. Whether it moves anything, but it seems to be that top down approach that the political types sort of run with something, but then it filters down to the Department of Health, etc., where they then give orders to the NHS or healthcare providers. These are things that we want you to do, sort of thing, like, you know. But getting hold of the political types is, I mean, I've written to them. I've never had a reply. I've tried to get contact them via social media. That was so, well, at least I had a go. But it's just grabbing their attention and say they're not even, when I've written to them, sent them the recorded letters, they've not had the courtesy to reply to them, like, you know. So it's a frustrating business, but I like this idea about going directly, you know, going directly to the public, sort of thing, like, you know. It's like, so perhaps, you know, like a campaign. And that's what I try to do via the webinars that we're doing now, like, you know, myself and Bronnie, we, you know, we was having just have a general chat last week, weren't we, about, and then let's do a conference for people in the Southern Hemisphere, like, you know. And it's our way, I suppose, in a way of how we can get it out there, you know, get the momentum going, you know, some people get interested in what pain self-management is, etc., like, you know. I don't know. I mean, I'm looking for answers myself. Like, I don't think I've exhausted all avenues, but there's probably ways out there. I suppose, in a way, we're looking for simple, low-cost ways, like, you know. But I mean, if we had a budget, an advertising budget, I mean, we could, you know, get cracking. I remember back in Australia that, you know, they did a massive campaign on back pain prevention. You know, they put it on the billboards in the area and stuff like that. And apparently, the incidence of back pain really dropped, like, you know. And
it's up again now.
Yeah, I mean, I've got a picture of a billboard, and that's as far as I can go. Well, I can whack messages. I was thinking of, you know, sticking sort, you know, I've got a picture of my van and putting different messages on my van, like, then post that on social media, sort of thing, like, you know. But I think, you know, I mean, I think that most people now are visual. You know, I still can't get my head around this TikTok business. You know, I'm slowly getting into the Instagram, like, you know, I see that as a good resource, very visual, when you can use closed captions and stuff. But it's that constant way of, you know, drip feeding all the time. No, you can't just say, oh, well, I posted it, you know, because you're relying on people that are looking. It's like people are watching this video. You know, not everybody's going to be watching a video, but how do we use this sort of, you know, visual promotion? How do we get it out there even more, like, you know? And so, as I say, I'm looking for answers. I'm looking for ways, because, you know, I'm not putting my feet up by any means. So it's a matter of just how do we get out there? I mean, we're coming up to 50. We've got another 15 minutes left, sort of thing. Like, so can you start thinking about what's the take-home messages we're going to get from today? What, you know, is there anything that you've heard tonight? Do you think to yourself, hey, I'm going to do that? You know, I'm going to, instead of, yeah, I've written a note about it, I'm going to action plan it, you know? I always remember sitting in a meeting once. It was a local, actually, when I was in the NHS, and there was a Russian decision maker that works within the local NHS, and I remember sitting in a meeting with all these bunch of people. And people would say, yes, I think I'll do that, and she would get up and say, yeah, so what's your action plan? When are you going to do it? When's it going to be completed by? I mean, it's to frighten the life out of people. I thought, I love this kid. Great, because she's actually saying to people, you've got to get out, you know, get off your, sort of saying, yeah, we could do that, make a note. You've got to, you know, when you're going to do it, you know, tell me, you know, what's your goal? How are you going to, you know, get cracking? Sorry, Mary, I've got to see your hand up there. Sorry.
No, that's okay. I was going to say, there is an obvious source of publicity and income, and of course that is government politicians, which of course is pretty hopeless. The reason that comes to mind is I've been working for over 2 years now on a low back pain project with a committee here in South Australia, and it's an excellent, we're calling it the optimal system of care. The first aim was to keep people out of the emergency department, because we've got like the rest of the world, clogged up emergency departments with ambulances ramped up as far as you can go. So that was our first aim, and then we aim to provide education and self-management, peer support, etc. And it's a, even if I do say so, we have got an excellent model there, but, and there's always a but, now we need some to be commissioned so that we can actually do a trial. And if the government won't pay for it, then I don't know where we go with it, because we need the money, we need somewhere to do it for a start, and the people to actually to do it. But that is one answer, because at the same time you're getting the self-management message across, and that's a win-win situation. I think you're keeping people out of emergency departments and educating them as well.
Mm. We need to start taking all, you know, people that ain't doing any self-management stuff like that. Do they need to be taken to court? Well, there's, I mean, I was watching.
White flags at politicians.
I know. Well, I'll tell you what. I was watching it. Well, we're watching the TV tonight, and because the government aren't, you know, this green, you know, going green, etc. And the UK government have you know, sort of slammed it in reverse, and 3 organisations have taken them to court, and now the government's got to explain on how they're going to reverse that, take it out of reverse, put it back into, you know, going forward again, like, you know. So I know it sounds a bit drastic, but you know, drastic measures. You know, I mean, we're all passionate about what we do. But you know, do we? You know, is that the way we change things? You know, I'm not suggesting, you know, demonstrating and whatnot. You know, but you know, legally or whatever. You know, it's only a thought. Sorry, Bronnie. I saw you. Just saw your name.
Yep. So my small action is to have been writing my blog. I put that out once a week. For health professionals, but also really people, anybody can read them. So that's my little bit, and I've been doing that since 2007, and I've hit over 2 million hits. So readership's not high, but it's there. And I think that perhaps we can link all of us are doing stuff. Perhaps we can link all of that together within our own platforms to say, hey, these are some of the resources that we know about that are constantly being updated. Back in the day when blogs were new, we used to have a list of all the, you know, these are my favorite sites. I don't think we do that as much now because we've become much more individualized, but perhaps that's something that we can offer as a on our own platforms. Here are places to go. Here are the resources. These are people. That way, we're going to increase the traffic to our own locations, but more importantly, we're showing strength. It's not just me in the wilderness, and diversity and accessibility. So I wonder if that might be a start. I also put that I think we need to have somebody with chronic pain who's a marketing strategist who would be prepared to help us develop a marketing strategy, because essentially that's what this is. You know, we are trying to market something that is not very sexy. It's not high tech. It doesn't look groovy. It's not new, shiny, but it's absolutely authentic and empowering. And that would be very cool. We could put the call out on this. You know, if you live with chronic pain, persistent pain, and you are a marketing person and you want to work out a way you can help, just call us. We'll do something.
Okay. Good. I like that. That's a good idea. It's a good start. Sometimes we need to ask for help, you know, and I think we've got the knowledge, resources, but sometimes we've got to reach out for help, like, you know, I mean, if you get a toothache and all that, I know here they take them out, take their teeth out as well because you can't find a bloody dentist, but But I mean, you know, generally you go and find someone to, you know, a dentist to take, to, you know, for the problem solving sort of thing, like, you know. And that's the problem we got. We know we've got the skills and knowledge, but we haven't got the marketing skills or professional marketing skills that we could use to do a better job, like, you know, a low cost way of doing it as well.
Without the clarion call over social media.
Say again?
Without the call over social medias, and let's see if anybody bites.
Yeah. Okay, we can do that. Perhaps we can do that on our own social media platforms. You know, we're looking around for someone who wants to do it for free. You know,
The world's our oyster. We're not limited to one country, so they can be from anywhere.
yeah. That's what I like about, so, you know, technology now, social media, etc. You know, this is our shop window, like, you know, where we can action stuff and whatnot.
Pete,
So,
would you be able to do some sort of overall statement that we can all put out that is cohesive, so we're all got the same message going out and we're all on the same page, and send it to us, and then we can all start plastering it as far as we can. We'll probably all put it in the same place, but that won't matter because it'll be seen by different people.
what do you mean for getting a promote
A marketing, yeah,
a professional?
marketing person with
Yeah,
chronic
sure.
pain,
Yeah, we wanted.
and sort of an advertising message for
Yeah, okay, I can do
a
that.
person, so that we're all saying the same thing. You know,
Yeah.
we're probably the worst case scenario, the best case scenario is we'll end up with someone. The worst case scenario is we'll end up with 50. Aren't I optimistic?
Well, they'll have to do it. They'll have to sell themselves, won't they? So we know when they sell themselves, we know the best one. Did
Yeah.
someone else? So we've got 10 minutes left. So come on, let's get our brain box going here. What's your action plans? What are you going to be doing? I know myself and Bronnie, we're doing our pre-ab. We got the Pain Toolkit Academy going launching on the 27th. What else we're doing? We're doing all these conferences and stuff like that. We're getting there. Listen, I'm not saying you've got to go, you know, it's just small things, but you know, what are you going to be doing? You know, just one little thing that you can take away tonight, saying, yeah, I'm going to be doing that. I'm going to go upstream. I'm going to get my paddle board out and get up there and make a difference to someone. Virginia.
You know, I'll definitely share whatever you share. I think that's a great idea. Let's get someone who's got some great knowledge behind them. But I'm about to also get in our community with a couple of the groups I'm working with. We're going to what calls Cafe Scientifics. Get right in our communities. Get right out there. Take the science. Take the researchers. Take the pain physicians. Take me out there and bring our communities together. And you'd be surprised. The last time we did it, we had 55 people show up at the venue. And we had to turn people away, and people waited to see if other people didn't show up to see if they could to come in. So people want to know. So I said, yeah, let's come down high and start low, start in your communities too, and get the word out.
Bronnie.
Grainne, you were going to say something on before.
Well, I was just going to say very quickly, I know I'd said what all the things Pete and I are doing together, but I am going to finally get my website up and running, because I loved what you said there, Bronnie, about what we should all do is, like, you know, get those, and what Jerry said about that woman's website with the resource pages is all these fantastic resources. That's what my dream for my website is going to be, that I'm not going to be selling people anything. I'm not going to be selling them kit. I'm not going to be selling else. I'm going to be, it's going to be information, and good quality information, like blogs, like stuff, that there are these people out there that is this information. So I'm going to finally get that going. I'm not a website developer, so that is going to be interesting trying to build my website, but I'm going to make sure it's good from the start, and it's got all this good quality stuff on it.
Mine is to work with we have a bunch of primary care clinicians called health improvement practitioners. They're originally for mental health, and they live inside general practice, which is awesome. Lots of them are occupational therapists, but there are a whole bunch of others as well. And they are seeing people with persistent pain, but they don't have enough information and knowledge. So my step is to create a course for them so that they can learn about chronic pain self-management. They use focused ACT, which is acceptance and commitment therapy, as their framework for all of their mental health work and all their other health stuff. And that fits beautifully for pain self-management. So that's my step forward.
Okay, well done, Bronnie. Susan, what are you up to, baby?
Yeah, for a while I wanted to connect the different universities across Canada with the pain curriculum, see who's doing what are we saying? And you know, in the step, like Bronnie was saying, take that worldwide then, right? What does the ISP have on? What does the World Federation of OT have on? But yeah, I think that's a step I need to start.
Tell you what, one of our colleagues come up with tonight. A lot earlier on today, I posted, I sent this post out, and as I said, all of us working in pain self-management are passing through history, which we are, you know, which is part of history today. And I asked, what would you like to be remembered for in history, in the history books? And Dr. Owen Williamson, who you all know over there in Canada, he said, suggesting people will change the conversation between people with lived experience or pain and the healthcare professionals and politicians by talking about supported self-management, you know. So, see, I mean, I don't know about you guys, but when I do this stuff, this really puts a lot of wind in my sails, like, you know, because, you know, when it's like you're in the trenches and it's draining, you know, that you sometimes feel that you're out there, you know, back in the war, like, you know, when the Civil War, the guy out there with a flag, you know, and it feels like we're out there and the flag's waving in the wind and all that, thinking, here we come, I'm going here. And then you look behind you, yourself, Christ, I'm on my own, you know, and that's how it feels like sometimes, you know. But I think a message really, take-home message for everyone watching this now, watching this video, the recording or listening to the audio version, is come and join us. You know, we want to hear from you guys. You know, what's going to be your battle plan? What's your action plan? What is your goal? How do you think you can make a difference? You know, what you're doing in your area. I remember Peter was in the last conference, World Congress. I can't remember his second name. Was it Peter? He's got his Christy. I know his wife's Christy. I think they was in. They moved to Denmark down doing some work over there. But he started up a walking group.
Yes, here in Nova Scotia, he did.
Yeah, that's it. Yeah, he started up a walking group, and someone saw the video in South America and started up a walking group. You know, and it's just simple stuff like that. You know, it hasn't got to be, you know, where you got to think about doing massive. It's what you know, just one thing. What would you like, you know, to do change, like, you know? So that's really, I suppose. What's your take? You know, just sum up. We've got a couple of minutes, 2 or 3 minutes left. So, what's your take-home messages from today's conversation?
You know, I think my take home and my action is, I was thinking all this stuff, and then I was like, you know, Pete, I think the thing I can do best is share the stories, right? I love sharing your stuffs, Pete. I love sharing Dr. Catherine Sylvester's story. I look at, you know, the work I can do, and we look at this huge system. And if I go out there, so I'm going to take your example one next, you know, Don Quixote out here, right? Fighting all the windmills, right? It's an endless battle. So where I feel best at the end of the day is how much other people's information that I agree with, that I believe are doing great things, have I given, I call it the megaphone, right? That I've opened up the megaphone for them. The Pete's, the Dr. Rebecca Seagraves, the people going upstream, the people going into underserved or less served areas, the people doing things outside of the norm, the inverted triangle. I like to give voice to them because I've been on places. So just naturally over time built up some kind of speaker. So I like to shoot stuff out through that speaker. So I still think that's, you know, part of my biggest value to bring to this whole thing. And then like taking the information I hear here, because then I use some of the stuff I hear here to talk with other people about, right? And so I think just being that, it's almost like, yeah, we all link up as resources, but then I'm like, okay, if we all continue to tell people, right? So maybe that's just the example I'm giving, is making sure I understand who the smart people are in the room.
Thanks, Jerry. Anyone else with a take-home message? Seb, you've been a bit quiet tonight, young man.
Yeah, you're being so young in my career. I'm just like, I feel like I don't have too many answers, and I'm just trying to.
Everybody's got. I was watching.
I'm just trying to absorb it all.
I saw on the chat there where you'd offered to do some awareness raising or something like that, and no one turned up. I mean,
yeah,
listen,
yeah,
dude,
it's frustrating.
frustrating. Yeah, it is. But I don't know. Can you hear my phone ringing?
No, I can't hear it.
No, because I'll tell you what, because it don't bloody ring at all for people wanting information. Self-management is a tough sell. I mean, if we was doing a good job, that thing there would be not ringing. It'd be ringing off the hook like it'd be red hot. And we don't have people queuing around a block, because trying to get people to self-manage and healthcare professionals thinking, well, I've got to change course here a little bit. How am I going to do that? Because that's going to add time to me day, etc. Like, yeah, but do they really want to hear it? And it's a tough sell getting those guys. And that's why I think it's important for us that when we're coaching colleagues, so healthcare professional, self-care workers, it's saying to them, this is how you promote and teach or coach self-management in those time-based appointments, so it's not adding time to their day. They don't feel this is another overload, like another broom I've got to sweep sort of thing. But it's if we can come up with how they can teach to patients in time-based appointments, self-management. I mean, that is a goal for us as well. Like, Susan, you got your hand up?
Yeah, just to piggyback on that, when I started doing the pain education prior to the people seeing the physician, so these GPs are referring to this tertiary pain program, coming to see the education, and they would tell their people, oh, you just have to do it, just get through, just jump that hoop, just go to the education. I don't know why they're doing that. And it was a real kickback, and I had some real discussions with these people coming through, and luckily my physicians were very supportive of it. But it took a very long time, and I was just shocked that it was the GPs that were the ones that were the stop. And so, yeah, when we talk about this being an uphill battle, it really is, and it's surprising who's going to be opposing us. But it did turn around, and in the end, I did it for 8 years, and by the end of it, I talked to over 10,000 people with pain. By the end, the GPs were referring just for education. So, Sebastian said, all of us, let's keep going, because it really, I was too stupid to stop, which I think is a trait that I have. I believed it was right, and I kept going, and eventually it did turn around, but it's going to take a long time. Yeah. But small steps, Bronnie, I love that. Small steps, that's my thing. Small steps.
Step at a time, day at a time.
Think of it like responding to the green, the need for global warming. This is really what we do. Everybody does little bits, and that's going to help.
Yeah.
So
I think we need a lot of work at grassroots level, and hopefully see the opportunities to branch out and contact other people and health professionals along the way. The more we can help people at grassroots level, I think the better off we are.
I agree.
Difficult though it might be. Yeah, we need another 50 or 100 years, which is ridiculous. But it's like that with everything, isn't it?
Do what we feel.
Everything moves slowly.
Yeah. So we're a few minutes over time. Has anybody got anything last to say? If not, well, I'll stop recording.
No, I just think that these conversations are wonderful. I think it's so much better. It's unique to have people just being able to have a chat and not sort of be sitting there listening to a presentation that you can't answer and all that sort of stuff. This is wonderful to just be able to sit here and just thrash it out. I think it's excellent. Even if we don't come up with some wonderful light bulb moment, at least we've come up with some ideas, and we've been able to talk, and I think that's wonderful.
Yeah. well put, Mary. And I think best way is to finish on that. I can't top that. Not that I want to anyway. So, so listen, guys, everybody out there watching the video, the recording, the video or the audio version. Thanks very much for watching. We appreciate you watching. Come and be part of our gang. You know, I mean, it's all about growing ourselves, etc. And let us know what you're doing out there in your part of the world, promoting self-management wherever you are in the world watching this. Okay. So again, thanks everybody, and we'll see you early part of next month. Take care. See you again soon. Ciao.
Bye. Bye, everyone.